and metaphorically.
Literally.
Yes.
Uh,
This week it has been probably both together.
Yeah.
Okay, we're on 10:01. Should we start? We have about 55 people. I think we can.
Sure. We can start.
Yes, yes.
Yes? Jyoti, you're ready, right?
Yes.
Yeah.
Yeah.
I think Jyoti
Swati will share my slides. Yes. Yeah.
All right. So very good morning
Yeah.
to all of you and welcome to the fourth in our series of the multidisciplinary team webinars that we have planned. An initiative started by the IPS West Zone Child Psychiatry Subcommittee, but we have a lot of partners, the Psychologists Collective, Indian Association of Physiotherapists, Indian Association of Physiotherapists Women's Cell, the Indian Speech and Language Hearing Association, and All India Occupational Therapists Association. The whole idea of doing this, as you know, it takes a village to raise a child, and it takes a multidisciplinary team to get that child who's having problems sort of back in that village. And that's the whole idea with which we started this whole endeavor. And we're very glad to see that it has actually received good feedback, and we've gone ahead and planned more. So the idea was to have 6 such sessions so that people who don't have access to multidisciplinary teams can understand how to liaison. Even if you're an individual, you can sort of create a network, which is a multidisciplinary network. And those who are in hospitals which have the setups could also understand how to further enhance that kind of an ideal setup. So with that background in mind, we'll delve straight away into the first case. This time we have not kept a diagnostic case which is going to be discussed. We have actually kept real life scenarios because the first 3 sessions were actual diagnostic cases and how to approach them, which were typical textbook pictures. Now onward, the next 3 sessions, which are now going to flip to the last weekend of every month. First was in the first Sunday of every month, is going to be real life cases presented by the faculty or the discipline who received the case, and then discussed by others where it may be necessary. So you will not find the entire multidisciplinary team like we had, one member from each, but whichever is relevant is going to chip in and speak, which is more like a real life scenario. As we have maintained in the past, the speaker will get 8 minutes, the subsequent discussants will get 7 minutes, and we request you to speak and stick to your time. There are no formal introductions. The speakers will introduce themselves and their slides will speak volumes for themselves. So without further ado, I, Dr. Alka Subramaniam, welcome all of you, and I will invite Ms. Jyoti Mohite, who is in our speech therapy department at Nair Hospital, very senior speech therapist and associate professor there, to kindly introduce herself and start the case discussion. You have 8 minutes, Jyoti.
Yeah, you have already introduced me. I think so. That's enough. That I'm from Audiology and Speech Therapy Department of Nair Hospital. So we straight away go to the case presentation. Okay. I'm going to talk today, as decided, we are going to discuss about diagnostic diagnosis. I'm going to present the case as a 23-year-old who came to our department with the complaint of difficulty in social interaction, and as mother reported, he does not use the social language appropriately. Known to him are Gujarati, English, and Hindi. Client had taken speech therapy and occupational therapy at a private clinic in his childhood because he had started speaking late and there was delay in his motor milestones. He has taken therapy from the age of 2.5 years to 10 years. And presently, he is only attending counseling sessions because of his anxiety issues, again in a private setup. He just came to us for certification purposes. Next slide, please. Yeah. So coming to the history, there was no significant pre and perinatal history. However, and postnatal history, but there was significant delay in motor and speech milestones. His walking started at the age of around 2.5 years. His first word was around 3.5 years of age, for which, as I told you, he has taken occupational therapy and speech therapy in the childhood. On the family history side, his father is known to have learning disability. Next slide. This patient is currently pursuing his post-graduation in VJTI. Yeah, next one. Okay. So when he came to us, he came with all these reports wherein psychological evaluation was done in our psychiatry department, where they said his IQ on WISC was around 132, which places him in a superior intellectual functioning. Woodcock-Johnson test was done where there was no evidence of learning disability, and on childhood autism rating scale, he was into mild to moderate range of autism spectrum disorder. Next slide. Coming to speech and language evaluation, informally, when we spoke to him, we found his comprehension was good. He could express himself in sentences of adequate length and complexity. Picture description tasks were given, so narrative skills were present. However, the important point was the descriptive details were missing. Next, please. On the pragmatic section, I for him to initiate, and he was unable to sustain eye contact. In terms of conversation, his topic initiations were poor, topic maintenance and turn taking though are present. However, if the topic is of his interest, he would initiate the conversation. He prefers solitary activities and social interaction. Little or no use of non-literal language, or he does not understand sarcasm, joke, metaphors, and does not use idioms. The client does not join an ongoing communicative interaction always. Next slide, please. Next, sir. Next slide, please.
Slide
I
has
am on the
changed.
next slide.
Yeah. Language evaluation on formal testing, we have administered KELP for language test. On that, his language age is more than 21 years, which is again a superior language, more than age appropriate language skills, except in the domain of pragmatics, where he was placed at the level of 6 to 7 years. Since he also, though he did not complain of any fluency issues, but while interacting with him, we found that he did have lots of word repetitions and phrase repetitions. He was using filler words and had prolonged pauses were observed in his speech. There were lots of physical concomitants like clenching of fist, lip tremors, and tension in the neck region. So stuttering severity instrument was administered, and the findings were suggested of moderate stuttering. Perception of stuttering inventory is another test where we check whether the patient has avoidance behavior, especially with regards to communication situations, and whether he can predict or he can expect when he's going to stutter. So on that test, we found that avoidance behavior was maximum, followed by the struggle behavior, and least was expectancy. Hospital anxiety and depression scale was also administered. So on which it showed there is borderline depression and anxiety. Next slide, please. So the provisional diagnosis based on all this, what we gave was social communication disorder with moderate stuttering secondary to autism spectrum disorder. Next slide. But since discussing about this diagnostic dilemma, the issues were whether we should really autism spectrum stuttering also gives to all these features such avoidance of contact, social withdrawal, anxiety, preferring to be alone. So all this. So should we really give him a diagnostic? I do agree that these two can coexist, but what we thought was the primary issue seems to be a fluency disorder, which was completely neglected. Neither the parents had complained anything about his fluency issue, nor he himself said so. But later on assessment was, and we could see that it is a case of moderate stuttering and lot of avoidance behavior can give rise to all such symptoms. So only when he reached here for specification, we did the diagnosis. Fluency disorder was totally neglected from their side, and probably because attendance also did not think about stuttering could give him disease.
Oh,
Yeah, so the dilemma whether he should really be labeled as ASD or not. That is why this case was chosen for presentation. Now the case is open for discussion.
thank you, Jyoti.
Yeah,
Yes,
I,
there was
I thought I was heard properly.
no, your audio in the end, there was just the last slide we had an issue, but it's okay. Now we are done. Thank you for sticking to time and that very lucid presentation. We will take questions in the chat box. So as you all have questions, please post them. We'll take all the questions in the end after all the discussants have finished. So our next discussant, the panelist today is the psychiatrist, Dr. Delnas Palsetia. Please introduce yourself and start your discussion.
Good morning, everyone. I'm Dr. Delnas Palsetia. I'm working as assistant professor in the Department of Psychiatry in Ayer Hospital. And after the case presentation, I would be talking about the differential diagnosis. So, next slide. So let's run through the key points in the diagnosis. So it's a 23-year-old patient. Current complaints were poor eye contact, inflexible adherence to routine, poor peer relations, low confidence, aggression. The speech and motor milestones were delayed. There was a family history of learning disability, and he had taken occupational and speech therapy for 9 years. The IQ showed superior intellectual functioning. On CAS-2 and ESA, it was suggestive of autism. There was no learning disability found on Woodcock Johnson. There was borderline anxiety and depression on the hospital anxiety and depression scale. Speech assessment, the comprehension and expression was fine, but the narrative skills and the pragmatics were affected. So was the fluency. There were some physical signs of anxiety, moderate stuttering, and on OT assessment, there was the eye contact was difficult to initiate and maintain. There was poor socialization and communication skills. And on special educator assessment, the eye contact was present but not sustained with poor socialization. So, given these key points, next slide. Next slide, please. So let's talk about the differential diagnosis. So when we talk about autism spectrum disorder, we talk about cardinal features. One is persistent deficits in social communication and social interaction across multiple contexts, restricted repetitive patterns of behavior, interests, or activities. And we often see these two cardinal features in the early developmental period, though they may not become apparent until later in life. However, ASD can be accompanied with language impairment as well. And this language impairment could vary in type and intensity, and they could have multiple contributing factors even for one individual. So, there could be language impairment in the form of difficulty with social and cultural cues and expectations, as we've seen in this case. There could be repetitive, rigid language. There could be uneven development of language. As we saw here, the comprehension and expression was fine, but the narrative skills and pragmatics were affected. There could be narrowed interests of conversation. So the topics of conversation would be as per their interests. And these difficulties are seen from childhood to adulthood. ASD could also be accompanied with social anxiety disorder, especially in high functioning autism, where we see internalizing symptoms. And this is because of the lack of insight and communication skills. And often anxiety can make autism worse. So children with autism, they often worry about making social mistakes. They avoid social situations. They would have inability to express the anxiety, which we call as alexithymia. And there aren't very standard questionnaires available so as to measure this anxiety. uh, as we talked about stuttering in this case, so this could be observed in autism as well, where there could be disfluency, that is physically it is difficult for the person to get the words out. Now we see that there is another differential that we should keep in mind is social communication disorder. So, social communication disorder shares with autism a common feature, that is persistent difficulties in social communication and interaction. However, the differentiating point is that we do not observe the rigid repetitive behaviors that we often observe in autism. And social communication disorder is often noticed later in childhood or even into the adolescent years. Next slide, please. This is a diagram comparing what features overlap with social anxiety and autism and what differentiates social anxiety and autism. And overlapping features, we've seen that there is often avoidance of social situations, gaze avoidance, and they often withdraw socially. However, there is social motivation in social anxiety. That is, there is desire to be social. Whereas in autism, they are often less social because they are often lost in their world of interest and thought. And so, social challenges that occur only in social anxiety are discomfort and fear associated with being the center of attention, whereas social challenges that are present in autism and in children who have anxiety in autism is often that they do not detect social cues and they are not able to express themselves during social interactions. Next slide, please. Uh, this we've already talked about, so I won't run through it again. This is a diagram comparing social communication disorder and autism. Now, the next slide. There's also another term that we should be familiar with, and that is non-verbal learning disability. And non-verbal verbal learning disability shares a lot of features with autism. It shares some features with communication disorders, learning disabilities, ADHD, depression, anxiety, and developmental coordination disorder. Next slide, please. But how do we differentiate between NVLD and ASD? In NVLD, we often have good verbal skills but poor visual processing, whereas in ASD, we have excellent visual processing. In NVLD, there is difficulty in visual spatial organization, whereas in ASD, we have sensory processing difficulties. In NVLD, they learn better by listening, whereas ASD, they are primarily visual learners, and the restricted interests and behaviors that we often observe in ASD are not observed in NVLD. And one thing that is common to SCD, NVLD, and ASD is difficulty in social communication and social interaction. So, this case goes more in favor of autism spectrum disorder, which could be accompanied with stuttering and social anxiety. So, it requires a multidisciplinary team to really work on the differential diagnosis. Thank you so much.
Thank you, Delnas, and thank you again for sticking to time and giving us that overview of a differential diagnosis. Next, we have from our psychology team, Sukhada Kelkar. Sukhada, please introduce yourself and let's see what she has to say.
Thank you so much, ma'am. And I welcome everybody on behalf of Psychologist Collective. I'm Sukhada Kelkar, and I'll be presenting the case on behalf in terms of the psychological purview that we could take. Next slide, please. So as per the earlier two demonstrations which were exhibiting and focusing on the kind of provisional assessment and diagnosis that has been created, as a psychologist, I think an important factor for me to look into would also be the current intake history of the client. So for me to begin with this, it will be a very good idea to sit across with the parents, create a very strong and a detailed intake clinical assessment and history into what is the client's presenting concern at the current point of time. So a thorough history should begin with adequate details on the perinatal, postnatal, and antenatal care and development. Similarly, as a child versus what is the developmental and sensorial profile that the client is presenting in the current status is something which is going to make a lot of sense. So a thorough investigation and a lot of input from the sensorial perspective would be needed as per an internal referral through an occupational therapist. So for me, all of these factors when it comes to the kind of sensory integration that the client is able to bring in into his interactions and day-to-day conduct, as well as his current behavioral history, emotional history, social history, and presentations in terms of what are those essential or triggering or precipitating factors and events which could have been connected with this difficulty in interaction. Also, a very important point which I feel will be needed at this point of time is to know that what is the age that the child or the client had been assessed in terms of his IQ. At the present moment, what I picked up from the conversation was that he's pursuing a postgraduate course in a reputed institution, which indicates that the person's IQ could be in a high functioning zone. But for the purpose of a psychological investigation, I would strongly recommend and go ahead to do with a proper IQ profiling, at least check for reports that there have been in the last 2 years, which will give me a good understanding of what we are looking at the present moment. Okay. Post that kind of interaction and investigation, the kind of assessment tools which can be of a lot of input and valuable recommendation would be, as I mentioned, the IQ assessment profile will give me a good understanding that what is the client's presenting concern and what is his actual performance expectation as. So the WISP will give us a good understanding and data into how does the client actually present when it comes to verbal appreciation, interaction, and collaboration versus his performance skills. Okay, so that could be a very important factor. Next, a thorough investigation in terms of his developmental domain, which will come from the autism spectrum of assessment. So certain tests like RADS or ASQ, when done in combination, will give a good thorough understanding about whether these concerns are more of a neurodevelopmental genesis or is there any other psychiatric perspective also which needs to be taken, which brings me to understanding and assessing the emotional and behavioral domain. So largely speaking, when we want to be assessing a client with these deficits, it is always a very good idea to see that what is the client's emotional profile looking like. So something like an ROR will give us a very good understanding of the client's emotional functioning at the current stage. TAT, which is a thematic apperception test, it builds very good insight into what is the client's subconscious dynamic and what is it that he's bringing into his day-to-day interactions as. Lastly, the empathy quotient is something which will give us good insight into what is the client's emotional makeup with a perspective of him being from the autism spectrum of presentation. Okay, now coming to the behavioral domain, it will be a very good idea to either run an MCMI or an MMPI, because what will be very specifically generated is that we'll be getting to know a lot of factors such as social introversion, paranoia, or is there a history of depression or underlying presenting problem or connected with depression? Because as much as can be seen from the information shared, there has been a diagnosis of depression and anxiety. Similarly, we'll also get a good insight into certain personality disorders which can be assessed if we are looking through the MCMI profiling. Okay, so this is with regards to the assessment that I would like to bring into the conversation. Now, next slide, please. A certain assessment into the differential diagnosis will also give a lot of information to us. So as I think Dilnaz ma'am mentioned, she did speak about the social anxiety disorder, which was formerly called as social phobia. So similar to this, certain other diagnostic perspectives also I would like to investigate into, of course, through a referral via a proper clinical psychologist. So ruling out on symptoms of social anxiety disorder, in which we need to check that is the client undergoing an intense and ongoing fear of being judged negatively or watched by others, because that is something which will also determine the quality and the way of interactions that the client is bringing into his day-to-day behaviors. Similarly, other group of anxiety disorders, something which I would like to check would be avoidant personality disorder. And the differentiating factor between SAD and avoidant personality disorder is that there is the core feature of low self-esteem which presents in avoidant personality disorders. So at a behavioral emotional level, is the client manifesting or showing any of these would be of a greater importance to understand and help us deal with the intervention and management of the client's perspectives. Similarly, going ahead with the differential diagnosis of GAD, that is generalized anxiety disorder, and agoraphobia. Again, in both these cases, we have to check that what are the thoughts and emotional patterns which are connected to how the person is conducting through his behavioral presentations. Okay. Similarly, going ahead, as we have spoken about earlier with the earlier presentations about social communication and pragmatics disorder, it seems to be that there is more focus on how the client is not showing the SCPD perspective because there is restricted interest, as we can see. But we will also have to check if there is any incidence of selective mutism, although very less likely with adults, yet it can be a good way of assessment. Similarly, ruling out for major depressive disorder and importantly, schizoid personality disorder. Okay. Last but not the least, Tourette's is also something that I would like to go through in accordance with what can be a presenting way and how is the client's behavioral aspect manifesting into his day-to-day interactions. Now, coming to the part of
You
intervention.
have 1 minute left. Please wind up.
Yes. Coming to the part of interventions, I think it is very important, as I mentioned, to understand what is the client's way of thinking, which can be connected and corrected through talk therapy using CBT and REBT modalities. Social skills training is going to be of high and umpteen importance, especially using the PEC system of communication, because that will make the integration of his resources much easier into his day-to-day interactions. Going forward, please, the next slide. Behavioral therapy in terms of using certain relaxation processes. Next slide, please. Behavioral processes and ideating that what is it that the client is experiencing in the mind, thoughts, emotions, and bodies. So creating strong body maps, getting the client to understand that which part of the body, in which kind of setting, and what kind of sensorial overload is he or she experiencing will help us greatly to help him create certain alternate relaxation programs. Similarly, getting the client to be rehabilitated into his social setting. So creating video analysis for him to understand how he conducts himself. Last but not the least, creating a long-term and short-term program is where the role of a psychologist will be of higher importance and much more of importance, because what will also help is with intra-therapy coordination of goals. So across domains, if the psychologist can be playing this role, it will really help in the kind of rehabilitation that we're looking at a long-term level. So with this, I kind of come to the end of my presentation points. Thank you.
Thank you, Sukhada. And I'm sure there's a lot to discuss. So those who are interested can always message her in the chat box and we'll take it up with the question and answer. Next, we have from the occupational therapy team, Dr. Sriharsh Jagidar. And please introduce yourself, Sriharsh. Start your presentation. I think you're on mute. No, yeah.
Okay. Do I have a control, Swati? Yeah, I have. So now, as an occupational therapist, now the person is diagnosed, a 23-year-old gentleman is diagnosed, or we have all come to the conclusion of him having social communication problems along with the primary diagnosis of ASD with secondary psychological affectations of mild depression and anxiety. Let's see. The keywords that I have picked up as an occupational therapist is one is 23-year-old. I must be aware about the need of a 23-year-old, what skill set is currently having and what needs to be learned. I know that the person has a 132 IQ and has mild ASD on cars, which I don't know how reliable it would be to have a cars for a 23-year-old. Also having borderline depression and anxiety and language pragmatic. So why occupational therapy would be needed? So most of you, and as even Ms. Sukada said, that sensory profile will be needed. But at 23, having sensory profile done, would we have a holistic picture? As an occupational therapist, I'm not really looking at whether the person is diagnosed, the number, the scales that has been administered, the scores, but I would see into what exactly is happening because of these problems, the occupational injustice. The person will not be able to participate in a lot of social situations where he will be deprived of, or maybe sidetracked. Being in a reputed college, there will be groupism, kind of subtle bullying, which we need to have a detailed history as being told by other speakers. Also, there shall be many opportunities that the person might be losing, and this problem with speech and inability to communicate, also having a lot of physical symptoms of anxiety might play a lot of role in having a good self-image as well as awareness about self. So using all the professional reasoning, using the ethical reasoning of how much and how many therapies a person should go, and also the pragmatic reasoning and the procedural reasoning of knowing what should be assessed and what should be intervened. I go on to my next slide of having an OT assessment, which is a three-pronged assessment. We all talked about the person right now, but as an occupational therapist, we just do not put the onus of entire problem or occupational dysfunction on the person. However, we take into the consideration the personal factors like how is his lived experience with the disease and what impact does it have on his day-to-day activities. As an occupational therapist, it's our dire role to understand the impact of this disease on his daily occupation performances, like a role of a student, a role of a friend, a potential partner, or even maybe just a being of a 23-year-old. We'll definitely assess for soft neurological signs because many a times if the child has a long history of having problems in delayed milestones, there are high chances that child will be having soft neurological signs, and we need to rule out whether it is behavioral or neurological. If it is neurological, then what? And if it is behavioral, then what? So as per the previous slides and the speakers, we can know the either the behavior therapy would work or sensory processing based therapy would work, or kind of simple physical remediation can work as per speech therapist suggestions. However, a sensory processing also would be taken through a detailed occupational history and even the sensory history that the person is showing, and where and an adolescent sensory profile can help us gain into the more understanding about whether the processing of the information that the person is seeking is well within the age criteria of the person. Also, the most important thing I do here for a 23-year-old, as his IQ is 132, is the self-awareness or the metacognition. We talked about CBT, we talked about REBT, but its implication of day-to-day occupation. So I would definitely look into the client centricity and the impact of this on which of the major areas of his daily performances. So a detailed metacognitive assessment can be done through an MCQ or executive skill functioning scale, and understanding the life roles that the person is playing and which roles he has been deprived of as a friend or as a son. There must be a lot of issues, interpersonal issues because of the language and communication difficulties, or maybe because of the neurological condition. We also go into looking for the task factors which may be hindering or maybe increasing the impact of this disease on his performance. Like in what situation is the stuttering happening? To what extent does it happen? And when does it happen? So also going on to the environmental factors, in which environment is the stuttering more, whether it is in the classroom, during the presentations, during an interview, or during a casual meet with the friends, or even outings. Where does it occur more, like whether it is with at the home, whether he's feeling better at the home, or how is it important for us to know what time of the day it happens? So scheduling the important sessions where the communication is of dire important according to the best time fit of the person, and how long does the setting occur. Like for example, in the presentation, we need to have the reviews. Ms. Sukada said about the video analysis, so we can actually video record a conversation in a demi setup or in a mock test, mock presentation video with the therapist, so that we analyze where exactly the stuttering occurred and how we can go about it, because there's also a history of repetition of words, and how can these be used for intervention. So I then move on to my intervention slide, where I use majorly. I'm not
Sriharsh,
able to.
you have 1 minute to wind
Yeah.
up, please.
So we have three pangs. So one is task-oriented approach. The person, as in the history, they said he has a stranger fear and a stiff neck. So for this, maybe when the neck stiffness happens, so maybe having a small physical exercise session, or for physical exercises for remediating his core muscle strength, which is really associated with emotional being, uh, showing him simple neck exercises as a kind of prerequisite to any kind of task wherein speech is required. What using a cognitive strategy around the concept of what does a stranger mean. So in the digital media, for example, I had a similar client wherein he had problem appearing for an interview in his or a meeting in his own setup. So when does this happen? So if he thinks that he's a stranger, how what exactly the stranger means? How can we kind of use digital media to understand about that person, reading about his profile on LinkedIn, Facebook, and making him familiar so that that fear of him being the person being a stranger is reduced. Also, understanding or quantifying the anxiety in terms of a simple scale of 0 to 10 so that he understands at what level what can be done. So, for example, if the person is feeling 5 to 6, a simple glass of water, so you go on to sensory based strategies or physical strategies or what the speech therapist has told. For example, he has to appear for a presentation, so he can use the exercises told by the speech therapist, the occupational therapist, the neck exercises, and the sensory based activities by the occupational therapist, so that the interference of the anxiety is less during the presentation. The newest approach that we use for patients with ASD is cognitive orientation to occupational daily occupational performances, where we look at the goal, we select one task where the stuttering is occurring or where the social communication is at the most, and even the perceived importance of having a remediation for it is important. We plan action with the client participation in the entire process. We actually set up this into a real-time situation and we check if the things have worked or no. And this all
Yes, we
as a
really need to wind up,
yeah,
please.
we are winding up, ma'am. So sensory-based approach will be what can help when you feel anxious, like either a hand massage, using a washroom, or drinking lukewarm water, breathing exercises, neck and shoulder exercises, altogether can improve his occupational performance in that task. With that, I end up. Thank you.
Thank you. Thank you. I'm sorry, but we have to stick to our
No,
time because we have
no problem.
only so much allotted to us. So the next person who's the panelist who's going to tell us a little bit about the educational aspects is Shobha Srivastava, who's a very senior special educator. Over to you, Ms. Shobha.
Yeah, thank you, ma'am. And let's move on to the next slide so that we don't lose time. Yeah. Yeah. Okay. So the case history shows that this could be a case of Asperger's syndrome or high functioning autism. And I can see that a lot of assessment has already been done and the person has been classified as having social and communication disorder. We can do many more tests, which have already been discussed and already been spoken about. But the point is that more assessment, I feel, is not required. I feel what is required is now intervention, which is of multidisciplinary, which all of us are talking about. And I will talk about the special educator one. I will first discuss the several steps that are recommended for the management, and then we will discuss the various teaching methodologies and methods to achieve these steps. It's most important for this person to have a productive life. When we say productive life, it is doing something of his interest, right? He's studying at VJTI, he has a very superior IQ, but is this what he really wants in life? Maybe he wants to do something else, which could be, a computer course, which will help him design something. Maybe his creative aspects can be explored. Maybe something of interest or maybe which will give him some joy has to be done. That I feel is very, very necessary. So occupational therapy has already been spoken about, and that will help him fine-tune the occupation which is identified for him. Physical fitness training, I feel, is something which will definitely has been proved to reduce all kinds of anxiety. This will help him increase his self-esteem and introduce him to more people, which will ultimately help him with the social activities. It is important, very, very important to give him more exposure to life. A creation of a peer buddy system, sibling support system can be put into place, which will help the person get exposure to various life situations to expand upon all his personality aspects. Several groups for adults with autism are available. There could be vacations and treks which he could take. There are running and fitness groups. There are social situations which are done. There are a lot of options which are available for him, actually. The next slide, please. Yeah. So pragmatics, we have already, a lot has been spoken about speech issues, and there's a lot of stuttering. And like rightfully said by the last speaker, it is important to identify when his anxiety levels go up. And that clearly results in stuttering. So that is a very good point which came up. So I feel that that should be measured. But more important than that is pragmatics in speech seems to be an issue. And without pragmatics to get along with day-to-day life issues seem to be very difficult. So speech training is already been discussed by speech therapists, but I feel that this has to be carried on with the entire team, which also includes the parent, the special educator, and expert, which can be built into his life and work area. What he's regularly doing, pragmatics has to be just taken up as a big challenge, which can be addressed and done. This can be done through very simple steps, which I will discuss very soon. Counseling on a one-to-one basis with him could help him get over depression, anxiety, as already discussed. This will be done by an experienced counselor who can sort out the various issues faced by the person. And counseling and guidance to parents and siblings also need to be done. I feel VJTI is a wonderful place for him to be with. But what kind of social situations does he get into there? Does he really have a friend system there which is actually enabling him to realize his potential to the fullest? Is he having problems there? I think these need to be found out definitely. Now, teaching pragmatics can be undertaken in the following ways. More social situations, like I said, like going to movies, going to malls, going to festivals, going to outings. All of this would definitely help out. If he gets anxious about stepping out, he can be explained these various situations before giving him the actual exposure. It can be aided with written and pictorial explanations of such situations in advance, which will help him overcome his anxiety. A role play can be done by creating situations where conversation is created about certain important aspects and expanded. Social situation, work situation, interest area mainly. I believe that he does take up his interest area very seriously and only talks about it. So it is important to explain to him that, there is also consent, that you have to start talking about an area if the other person is interested in. So that is something which he could easily understand. Video modeling can be shown to him. Lots of videos are available online to look at to understand what kind of behavior and what kind of conversations can take place in social situations. Reading passages and answering questions about serious topics like global warming and questioning him about it, which will make him understand at a macro level. Promoting reading of more pragmatic approaches to life, like the daily paper, and then having discussions about it and maybe writing a short write-up will help him definitely improve his pragmatic approach. Next slide, please. Some teaching methodologies which work well with individuals with autism are social stories and social articles. This has already been discussed, but basically they are rules and situations by Carol Gray. Social article, on major topics, like I said, like global warming or maybe water crisis, which we are faced in the country, importance of hygiene. Now, these are things which he may or may not understand in the depth. And that, I feel, is something that we should bring about, a compliance to understanding and a consent to understanding more things about it. A general situation can be written by him or for him, and the next one should be written by him. This can definitely happen. Comic strips, conversation strips about situations can be written for him, and he can later be guided to write the same for different situations. This prepares him for the variety of situations which he will face in life. Conversation cards, he can be guided about conversation starters, and these can be simulated first. Important to inform him that the other person needs to be interested in the conversation for him to proceed. This can be done one-to-one first, then with a small group, and then expanded to get more practice. Demonstration of conversations can be shown, and then real-life situations can be created, generalized, created through video modeling. A lot of things are already available, but more can be done on an individual basis. Safety rules, very necessary so that he knows his boundaries in social situations. People can get very excited with him and he can get excited about situations, but it's important that consent is a concept that he needs to understand and he should live by it. Some leads to social activities. Okay, good. We are on the right slide. So some leads to social activities. Extra leisure basically is running the marathon. Of course, his fitness levels have to be first diagnosed by a medical practitioner. If he's fit enough, I feel a lot of his anxiety issues and his stuttering will definitely reduce, and increase in self-esteem will happen. So there are clubs at Borivali which train special adults. I don't know where he stays. I presumed he stays in Mumbai. But there are similar such places available in other cities, which looking at the popularity of things like the marathon. Maze Charitable Trust, it's available on FB, which organizes treks and vacations with or without caregiver support. Very, very popular for many individuals with autism. A gym with a good quality suitable trainer, or a trainer who trains a few people together would be a very good choice for this person, because it gives him an option to develop more socialization. Safi, Self-Advocate Forum for India by Parivar Trust. Lots of opportunities for getting into a group of similar individuals where he can meet others, he can talk about his experiences, actually travel with them, which really is good. There is a special Hangout group which is on FB and a WhatsApp group which connects individuals and families for a whole host of leisure and partially academic activities. Creation of a small buddy group is eminently possible. So all of these can definitely lead to a productive, motivated, happy individual. Medication, of course, should be the last option, which should not be discussed at all, unless there are, of course, extremely aggressive behaviors, which will come in the way of living a productive life. Yeah. With that, I come to the end of my presentation. I hope I'm on time.
Thank you. Yes, yes. I can always expect a teacher to stick to time. Thank you.
Thank you.
All right. So we have a few questions in the chat box, and those of you who want to post your questions, please continue posting them. The first is, can CARS be a reliable and valid assessment tool for adult autistic individuals? That's from Yash Dedia. Anyone wants to take that? Delnaz, do you want to take that?
Ma'am. So CAS2 high functioning is used in children with ages 6 years and older and with IQ higher than 80. So CAS2 high functioning scale can be used.
Okay. And usually for diagnosis in India, we use
Like
the
incline is used. This is more for severity. To measure severity, we use CAS2 and ISA, Indian scale for uh,
assessment.
assessment of autism.
That's
And yes, thank you.
okay. Thank you. How can we, Stuti has asked, how can we deal with the preschool child having autism in school? So any measures, I think maybe Shobha can take that.
Yes, I've already mentioned in the chat group that early intervention services by an MDT team is what will really work. But things like floor time, joint attention stimulation, eye contact development, these are the important points at this stage. And this is a stage of miracles, the early intervention stage. So a multidisciplinary team doing each of the legs but working cohesively together would really work, yeah, to bring about the change.
Absolutely. So early intervention is actually more of the norm rather than the exception in child psychiatry. And the earlier we diagnose and the earlier we intervene, we do find it makes a huge difference. The next question is from Dr. Jyoti Shetty, who has asked for an adult high-functioning ASD with communication issues and professional training, maybe specifically what primary psychological measures or interventions would help. Sukhada? Sukhada, you want to take that? Particular interventions for a high-functioning ASD with communication issues?
Can I answer?
Yes. Sriharsh, please go ahead and answer.
So here we are looking at the psychological, psychosocial development of this kid. So even if the intelligence, the IQ testing only assesses a certain part of cognition or intelligence, the more about of somebody mentioned about the empathy quotient also, but there are a multi-pang actually multi-pang aspects to cognition, and most important being social cognition and executive functioning. So the what psychological help we can extend to the person is by understanding the insight that can be given to this patient about his condition. The more he understands about the condition, the more he'll be in control of it. Adding advocacy to the entire, like we used to this thing, either accept it or learn it, or so having a conversation related to whether when to mask the deficit, when to accept, or put your weapons down, like I'm sorry, I'll get back to you after a while. So understanding this concept, understanding the limitation and the strengths of the disease is very important. So I would say that improving the insight and the acceptance of the condition by the person, and at larger the immediate environment which where the person is interacting in, will help by having a better outcome.
Thank you, Sriharsh. Next question. There's a comment also. Wonderful presentation from all of you. As spoken in the presentation, how effective is it to use PECS, that's Picture Exchange Communication System, and social stories for social communication in this 23-year-old neurodivergent with superior intellectual functioning? Jyoti, you want to take that? Jyoti Mohite.
Yes, yes, yes. PECs, not really PECs per se, but yes, social stories still can be used as already mentioned, because PECs is very different. The level of training, it is just for exchange of communication where a person is not able to communicate even basic needs if we go step by step for PECs. However, yes, for higher functioning, it is like an indirect way of teaching them this social communication. So social stories definitely can be used.
Yeah, so we usually use the PECs with a little, when there's more of non-verbal communication and
Verbal, yes.
people. Social stories is when there is a better cognitive ability and there is some amount of verbalization. So yes, definitely that would help. And the last question that we have for this panel is non-compliance and less motivation to have a physically active life, including routine fitness regimes. If found, how can it be managed? Archana has asked, and I suppose that is not only for neurodivergent, that's for everybody, including all of us. So if anyone wants to answer, how do you motivate people to have a more physically active life, particularly in this case?
Uh, So
Yeah,
when the person comes to any kind of therapy, it is so rather than understanding, as I said, about increasing the insight. So first, we all know about our bodily state, like where is the pain, where is the palpitation. So and making the person realize about the mind-body brain connection. So how physical exercises will help in reducing anxiety? How will he feel after, like mindfully doing those exercises? So that he feels better, more confident, have a positive self-image. So having a regime, making a occupational therapy or some kind of a regime, so that
Wow,
physical
Vishnu,
activities
what
become
is
a part
this?
of a routine, which become a part of a routine.
What is this, Pichka?
Can I add to this? Ma'am? Shobha
yes,
Srivastav here. Yeah.
yes,
See,
please go ahead.
I think fitness is something which, we have made it very, it's like a military training. I feel we need to think about what the person may like, maybe like a dancing situation, maybe just, moving their body, maybe, just becoming aware, doing something fun and then making it like an exercise routine. Yeah. So that will motivate the person also to do it more. And persons fall into routines very quickly. So basic, with music and dance and make it fun and having more people of his, kind together, I think would motivate him to get into a regime like that.
I've also found that with higher functioning adult ASDs, sometimes, when we challenge the cognitive reasoning and we explain to them the benefits, actual medical and physical benefits of exercise, and they get hooked onto that, they follow it with great discipline. So sometimes using that, usually what other people think is a sermon and is not motivating, that we know, everyone knows exercise is good and one should do that and one should, but for them, it's almost like they take it at the gospel truth and then they go ahead with it. So that is possibly a strategy which one can try. So excellent. Thank you all the panelists. Jyoti, starting with her, she presented beautifully. Delna, Sukhada, Sriharsh, and of course, Ms. Shobha, who has given their inputs into this case. I think the diagnostic dilemma that we started with about the case has actually evolved into possibly a dual diagnosis or existing temperamental anxiety with a grafting of ASD. And we often see that ASD and anxiety coexist and may manifest in various ways. So let's not go running after diagnostic labels and semantics, but try and understand. Of course, those are important for us for disability benefits, educational benefits, so on and so forth. But let's try and understand that each individual has certain needs and we have to find out and tailor make and cater to them. So thank you very much from panel 1. And we move on to panel 2, and I'll hand it over straight to Dr. Jyoti Shetty, who's the chairperson of our committee, and she's going to moderate that.
Thank you, Dr. Alka. That was a wonderful panel. And thank you all the panelists that attended.
Sorry, can I disturb you? I'm sorry
Yeah.
to interrupt. We
Yeah.
have our president actually who has joined us, Dr. Neena
Yeah.
Sawant. Maybe you want to ask her to say. a
Dr. Neena, do you have anything to say, comment? I know you have commented your excellent discussion and presentations. Could you please join us briefly, if you
And
can?
thank you, Jyoti. No, it is going on very well, and we are keeping the time. And I think, yes, as Alka said, the diagnostic dilemmas are no longer dilemmas. And like I said, we are too focused on, diagnosis. So somewhere where we look at the symptoms and bring about a change in the person's life, that is what we all need. So I think it is going on fine. And yes, now on to your session.
Yes.
Looking forward to it. Thank
Yes.
you.
Thank you. At the outset, I think just to repeat, the first presenter, this time we have the second case is going to be presented by a pediatrician, would have 8 minutes and the panelists subsequently 7 minutes. We have kept to the time in the first case. So I think it is expected that the second case would go also similarly. Also in between, I would like to request Dr. Swati, and I don't see Hitaf, but we could put our feedback form on the chat box. So we would definitely love feedback on this webinar and to plan the future webinars. As Dr. Alka said earlier, I think the next three, that is including today's, we have flipped to the last weekend, the last Sunday of the month. So it's been a very good 4 months of such multidisciplinary teams interacting on such cases, and on to the next case. Yes.
Hello, good
Dr.
morning.
Swati, yeah.
I'm Dr. Komal. I'm a physiotherapist, assistant physiotherapist at Early Intervention and Rehabilitation Center for Children, TNMC and BRL Nair Hospital. Next slide, please. So I'll be presenting a case of Johanna. She's a 5-year-old, 1-month female child. Her GMFCS level is 4, and she came with the concerns of developmental delay in gross motor, fine motor, and speech. Her mother's age during delivery was 38 years, and the father was 40 years. Prenatal history: she's born out of non-consanguineous marriage, and mother had hypothyroidism during pregnancy, which was she was taking medications, and she was conceived naturally. Mother had taken all the medications and TT injections. Her status is gravida. She's 2, parity 2, live 2, abortion 0, and death 0. So Johanna has an elder sister. Now she's around 12 to 15 years. She was on regular sonography checkups. Antenatal scan was suggestive of inappropriate development of the child in the 7th month. Also, during history taking, I asked the mother how was the fetal movement. So, mother told that it was normal. Then comes the prenatal history. She was a full-term normal vaginal delivery and vacuum assisted with prolonged labor of 12 hours, cried immediately after the birth, and her weight was 2.4 kgs. Postnatal history: she was admitted to NICU for 1 week in view of abnormal limb attitude, that is AMC. She was on and off admitted to the hospital as she had recurrent chest infections. She was on homeopathy medications for 2 years of her life for the same. MRI was done, which was suggestive of syringomyelia. Developmental history: so all her gross motor, fine motor milestones are delayed. She cannot sustain any motor milestones on her own, needs supervision or support. Next slide. So you can see from the tables, gross motor and fine motor, both the milestones are delayed. For language milestone, now she can just say 2 words, monosyllable word, that is give and no. Social milestone: she's a very happy child, likes to play in group with everyone, and she likes to make new friends. She can share toys with others, understand simple commands, recognizes person by name. Next slide. her surgical history, she had a corrective surgery for her left CTEV. In 2019, bilateral adductor release, left tenotomy was done with right tibialis anterior release and bilateral AK POP cast with knee flexion done. MRI. So investigations part, Dr. Shrishti from the pediatric department will be telling you about the investigations. So I will be just highlighting a few. MRI was done which was suggestive of abnormal white matter in certain parts of the brain. In her genetic report, no significant variant was detected. And EMG NCV, so EMG for upper limb was normal. Lower limb MUAP was not generated as there was no voluntary contraction reported. NCV, so there is chronic sensory motor deficit in more in lower limbs than the upper limbs. Blood investigation, so her D3, D4 levels are little low, that suggests of insufficiency, and her aldolase is high, that is 32.8. Next. On examination, we can see that her she has low set ears, she has left squint, she has arthrogyropsis of all the four limbs, she has club fingers, she has short neck. So, clinical suspicion is arthrogyropsis multiplex congenita type 1, club fingers, short neck, talipes equinovarus, that is CTEV. Sensations are intact, reflexes were diminished, superficial and deep. On her motor examination, her all active ROM for all the joints, they are restricted, and her movements of the limb are very slow, that is bradykinesia is noted. Contractures, so there are multiple joint contractures. Tightness, she has TA, hamstrings, hip flexors, adductors, bilateral tightness. Limb length discrepancy, so her left leg 1 inch is shorter than the right. Tone, there is hypotonia all over the body. Arousal, it is low to high. Affect, she is sometimes happy, sometimes flat affect. Attention is fleeting. Her action is always goal oriented and purposeful. Her base of support is narrow. A center of mass is always anterior. Strategies of stability, she uses momentum to do any activity. Anticipatory control, it is very poor. Postural counterbalance is poor. There is no dissociation seen as such actively what she can do, any trunk rotations, any trunk segmental rotations. Activities of daily living, so her all ADLs are dependent on the caregiver, that is father, mother, and her sister. She can eat finger foods, but she needs assistance and she needs a good sitting balance. So she cannot sustain the sitting for long. Mother can help, like while wearing clothes. So she can put her hand inside a t-shirt or a pant, and then while bathing also she can hold a half filled mug in her hand and she can try, but if she has a support, she can sit back support, then she can do hand activities very well. Her ball bladder, she understands when it is wet and she can point out if she wants to change. She can express her emotions, that she's angry, happy, very easy. Next slide please. So you can see the image which is on the first. This was just one when she was 1 month old. You can see all her limbs are adducted. She has club fingers. She has left CTEV, and usually like she was like a stiff in one position. And now what the image, you can see down, she is Joanna, and for the treatment purpose, so now first parent education. So she had lost to follow up because of financial crisis, but at EIRC this is free of cost. So she has now again continued for therapy here, and exercises. What I suggest here in EIRC, the mother is taking those at home also. Next treatment goal will be elongations and stretching. As you can see that we are making her actively elongate her hamstrings TA by giving a reach out and using A4s and sprints while standing. Core strengthening to improve balance. So usually we take her on a ball, we do rolling, prone extensions on the ball to improve her core strength. Dissociations to improve mobility. So here, while standing, you can see her interlimb and intralimb dissociation with trunk and upper limb dissociation. So she is reaching out with the ring and putting the ring in the stand. So she has to go forward and put the ring in the stand. Also, every Saturday we usually take group sessions. So she is highly motivated. She participates in all the activities, and that encourages her to perform better. Uh, Next is body weight support standing using harness. So at EIRC, we recently got this body weight support standing harness that enhances the risk, reduces the risk of falls, and it provides a secure and controlled environment. And it has adjustable support, so it has chest belt, it has pelvic support. So in the start when she had come, we had started with the chest support also. Now you can see in the image that gradually the chest support has gone, and now only pelvic support is given. That also aids neuromuscular re-education, so proper movement pattern, muscle activation, and also it gives a sensory feedback.
Komal, there is very little time. Can you finish?
Yes. Next is aquatic therapy. So aquatic therapy, it gives an environment where the physical properties of water, it assists reducing the body weight, and it also promotes free movement with less resistance. Also, next is the functional electrical stimulation which we use. So it is a mobile based application which we connect via Bluetooth in our phone, and it has adhesive electrodes which we put on the muscle belly for activation. So now currently our goal is that she should sit properly with good sitting balance and hand supported. So we usually apply that functional electrical stimulation to bilateral tricep for a good activation, and then she has to do a reach out on the opposite side, where she has to, one side she has to extend and the other side she will reach out for the same. That's it. Thank you.
Thank you. Thank you, Komal. And since we have, I think, exceeded the time, I would invite Dr. Shrishti, who is a pediatrician, to give her points. And Dr. Shrishti, you have 7 minutes.
Yeah. Am I audible?
Yes, yes, you are.
Myself, Dr. Shrishti. I'm MD Pediatrics working at EIRC. So let's begin with the presentation. As you know, a brief about the Johanna's case. She is a 4-year-old female child, second by birth order. She presented to EIRC in February 2023, and she is regularly following up in EIRC. As you have noticed, that she has a difficulty in motor and fine motor, as well as difficulty in chewing food, unable to speak, sleep issue. This child has lost follow-up in 2020 due to financial constraints and never evaluated further. So parents now came. So we have, Komal has brief about the birth history, antenatal history. I would like to focus on some important points about the birth history, which has helped us in to conclusion the diagnosis. That birth history, the child was vacuum assisted delivery, 2.2 kg. She was a term child, but still she was a small for gestational age, like she was weighing less for the approximate weight. She was admitted in NICU for congenital abnormalities and not for any neurological deterioration. So the points noticed was dysmorphism of the face, that low set of ear, and abnormalities in the lower lip. So diagnosis was made that arthrogryposis multiplex congenita type 1. It means that the distal joints are more involved, and she has a left CTV, Pirani score is 6/6, means it was a severe most left kind of CTEV, congenital talipes equinovarus deformity. So when the child has some congenital abnormality, they usually screen with MRI to check for any other neurological involvement. So MRI screening suggestive of syringomyelia at level D12 to L1. Syringomyelia is a cystic cavitation which present in the spinal cord, and that may cause the symptoms of pain and scoliosis and other problems. Developmental history, as Komal has already described you, the child is a global developmental delay, has not achieved age appropriate milestone, but the child social interaction was better. She was smiling even before 6 months, recognizing mother, father, and sibling. She is not able to speak. Sometimes she says ma and some gesture pointing, post voiding urine, but usually after passing the urine. Next. It is important to look at the anthropometry of the child, which we see weight, height, and head circumference. Head circumference is an important neurological assessment because microcephaly is a clinical examination of showing antenatal insult to the child or peripartum insult. So as you can see, head circumference Johanna is -2 SD. She is not a microcephaly. Weight is appropriate, but the height is lagging. Her vitals are stable. She is a gross motor functional scale is 5. She has a dysmorphism. There are web spaces in the fingers and short neck. She has a squinted eyes and delayed and loose teeth. Cranial nerve examination, we could only assess few cranial nerve, which includes hearing and vision. Gag reflex we check so we can assess her swallowing difficulty. In sensory system, we only examine tactile, which was present in upper limb, but lower limb we could not perform. And other sensation also, we have a difficulty because the child has a lot of increase in tone and difficulty in movement. One more thing we have noticed in the child is she was noticeably very slow in reaction to command while picking up things. Her tone was increased in all 4 limbs, specifically upper limb, and bilateral contractures were present in the ankle. With the right ankle was very stiff. Upper limb, the power of we graded is 3/5. Lower limb restriction was there, but no movement at ankle bilaterally. So our clinical diagnosis was global developmental delay with dysmorphism with operated left CTEV in case of congenital arthrogryposis multiplex complex. I will be referring arthrogryposis my AMC. Arthrogryposis multiplex congenita is a type 3. Why we are labeling it as a type 3? Because AMC has 3 types. Type 1 is associated with distal anomaly. Type 2 is associated with other anomalies like gastric malformation, liver malformation, and type 3 is associated with CNS abnormality. The second differential was that Johanna can be a syndromic child with genetic abnormality, or Johanna might have some myopathy with AMC, or she can be just a neuronal migration disorder with a spinal bifida defect. What is AMC? My colleague will be explaining more about AMC, but I would like to tell you this is a AMC means more than 2 congenital joint contractions are involved in the body part. The common cause of AMC is a lack of movement due to akinesia, which might be primary or secondary. Primary means the child, the intrinsic factors are in the child, maybe myopathy or any defect at birth, and extrinsic factor related to mother, infection, oligohydramnios, advanced maternal age, which are contributory, but the exact cause is unknown. AMC is also important to be considered because intellectual disability is observed in these kids about in 25 cases. And AMC is diagnosed so far with the 400 gene identified with link to the AMC. And there are several X-linked disorder, which is consistent with the primary with intellectual disability. Next. That's why we approached the Johanna's case with a 3-4 test. We asked for blood tests, we check thyroid level, we check for CPK, MRI brain and spine, nerve conduction study, and followed by AMG and some genetic test. Next. So this is a NCV study of Johanna's. As you can see, I have highlighted the peroneal and sural nerve, where you can see the very decrease in amplitude of both the nerves, that is the peroneal and sural. The remark is like the sensory nerve conduction is decreased in the sural nerve, which is decrease in amplitude as decrease in conduction velocity. While in motor nerve assessment, we found this the decrease in peroneal nerve and decrease in amplitude and decrease in conduction velocity. What is the interpretation of this? Neurodiagnostic ticks are very complex to interpret, but we can see when there is a decrease in amplitude and decrease in conduction velocity, it implies the axonal injury, as well as it is a bilaterally symmetrical and decreased amplitude and conduction velocity. This implies that there is a chronic sensory and motor axonal damage to the lower limb as compared to the upper limb. So we did EMG also, as the Johanna has a multiple contracture, and in pediatric age, we do not check all the muscle of the body. We check the specific muscle. So we did in upper limb, we check deltoid, and in the lower limb, we check for gastrocnemius, where we found the EMG was normal in upper limb, but in lower limb, motor unit potential was not generated because the child was not doing any voluntary activity. Next.
Your 1 minute, Dr. Shrishti.
Yeah. The MRI of the brain of the child was showing parietal lobe involvement, bilateral thalami was small, dorsal predominance of thinning of corpus callosum, and diffuse thinning of optic nerve and chiasma. These all are related to the white matter degeneration, but we do not find the cause of this degeneration. This might be demyelination, means there is a defect in the myelination since birth. While the spine spring at 4 years of age, we found that there is a low-lying spinal cord which ends at lever L2. Genetic testing with arthrogryposis, a genetic panel was tested, but we did not find any related phenotype. Next. Because there is about 30% of cases, genetic cause can be found, but in Johanna's case, we did not find any obvious anomaly. One more thing is noticeable that in almost all cases, most of the cases of amyloplasia is sporadic. Amyloplasia means muscle absence, which can be sporadic. And there are why we require genetic testing in Johanna, because there can be X-linked recessive type, which will have recurrence risk in the future progeny. That is why we have screened the child that we could find the cause. The prognosis and treatment, the main point is to remember is AMC is not a progressive disorder. In Johanna's case, parents will require a further genetic counseling because they have one more elder sibling, 15-year-old female child, and we should find out all the genetic abnormality which runs in the family. We have to explain the parents the realistic goal for the child with physiotherapy and occupational therapy and speech therapy. Medication for spasticity has been advised. Orthopedic intervention and follow-up for CTEV, because this child will have more chances of risk of arthritis in future and scoliosis. The child needs to monitor her health and development. As you can see, the child has a spina bifida defect. There is not yet achievement of control of bladder. It is early, and as intervention is important is CIC, that is catheterization, intermittent catheterization, to help to prevent the infection.
Thank you, Dr. Shrishti. Yeah, on to Dr. Akshay Pawar, who's an orthopedic surgeon. I would request all speakers to keep to the time of 7 minutes, please. We have already exceeded with this. Yes, Dr. Akshay, you can introduce yourself and start your presentation.
Yes, am I audible to everybody?
Yes, you are.
Yes, yeah. I am Dr. Akshay Pawar, and currently I am working as an assistant professor in Department of Orthopedics at Nayar Hospital. Yeah, so this is the short history and the clinical findings from the orthopedic point of view. Joanna is a 5-year-old female child. On history, she has gross developmental delay with motor milestones significantly delayed. There is no significant perinatal history. There is no history of seizure disorder. The current issue is difficulty in motor skills. That is, mobilization issues are there. She is not able to sit from lying down position, unable to stand and walk, crawl. Bowel bladder is not well trained. Lower limb spasticity and is there, and the reflexes are risk. There is a contracture of both side hip, knee, and ankle joint. There is a flexion deformity of 20 degrees in both the knee joints. reference to the limb length discrepancy, there is only apparent limb length discrepancy of 2 centimeter. Both foot CTV deformity is there. Right side it is almost corrected, but left side it is partially still there and it is yet to remain corrected. The limb length discrepancy is only of soft tissue that is due to the adduction contracture of the left hip. There is on X-ray examination there is no bony shortening is there. Metabolically, such children usually have hypovitaminosis, that is the rickets, and the classic features of rickets like low calcium, low vitamin D, increased alkaline phosphatase that is present in such cases. From neurology point of view, the NCB study shows chronic sensory motor axonal neuropathy, damage in both the lower limb. EMG in upper limb is normal. Lower limb muscle. EMG in upper limb is normal. MUAP is not recorded. MRI brain shows sequelae of prior incident-related changes in bilateral cerebral hemispheres. Next slide, please. From the management from orthopedic side, the main point to remember that the current diagnosis, that is arthrogryposis multiplex congenita, or query, it is also a kind of cerebral palsy. Both these are not a progressive disorders. In cases of for the management of the medical management consists the management of rickets with oral calcium and oral vitamin D3, so that the bone stock is maintained. To decrease the muscle spasticity by muscle relaxant such as oral baclofen, she has already been started by on baclofen since a long time. To improve the muscle power by strengthening exercises of the hip and knee. Currently, the power is almost 4/5 in the hip and the knee. If the power is increased to 5/5, then she might be able to stand on her own, provided the hip contractures are treated. Another management is to prevent progression of the muscle contractures by stretching of the hip, knee, and ankle joint muscles. To mobilize the child with ankle foot orthosis and knee extension brace so that the flexion of the knee joint is countered. Another point to note is classically she is the age group of 5 to 6 years. Such patients are usually given Botox injections in the hip and the knee joint. But here the difference, that is the R1 and the R2 angle difference, is less than 30 degrees. So she is not the ideal candidate for Botox injections. Also, such kind of children, the prognosis and the life expectancy is poor, as such patients succumb due to complications of immobilization and chest infection. On history, she also had an episode of pneumonia 2 years back, for which she was admitted in a ICU setup for 20 days. So she might get, chances are that she might get frequent episodes of pneumonia later also in life due to delayed mobilization. Next slide, please. Next slide. Yeah, so this slide represents the various deformities which she is currently having. In the first picture, you can see there is the knee joint deformity, flexion deformity of almost 20 to 30 degrees. Also, in the second pic, you can see that the left side knee joint has gone up. So there is shortening of almost 1 centimeter. There is no bony shortening, but there is shortening due to the adduction contracture of the hip muscles. Also, in the previous slide on the X-rays, there is a left side hip subluxation that is causing the shortening of almost 2 centimeters on the left side. So care has to be taken to correct the hip subluxation. In the final slide, you can see there is a left side congenital talipes equinovarus deformity of the left foot. This has been partially corrected, but a slight amount of deformity is still there. The current orthopedic management plan is to correct the hip, knee, and the ankle deformities by tendon release surgery of the hip joint, that is the hip flexure, which is the rectus femoris, and the knee hamstrings. For the foot, the correction is to be done by posteromedial ankle and subtalar release surgery. For the left hip joint, to prevent further subluxation of hip joint, adequate amount of splinting such as abduction pillow night splinting and left adductor release surgery is to be done. Also, it has to be noted that post-op aggressive mobilization of the child with assisted devices like cerebral palsy walker can be done, which is shown in the right side, right upper corner pic. Also, it has to be noted that surgery is right now not ideal stage for currently is not ideal at this stage. So currently, she will require aggressive physiotherapy to improve the muscle strengthening, to gain the coordination by use of physiotherapy for the next 3 to 4 months. And later, when the status is slightly improved, she might is it is might possible to undergo surgery for her to get the further benefits of to encourage her to mobilize her more adequate. Thank you, ma'am.
Thank you. And thank you for finishing slightly before time. I would request, thank you very much, Dr. Akshay. I would request Dr. Trupti, you can self-introduce and start, please.
Good
And
morning.
here I would like to say that please don't reiterate the history. You can just focus on the areas of intervention.
Myself, Trupti Nikharge. I'm an occupational therapist working at Nayar Hospital. My first question is, the physiotherapist had said that the child has hypotonia, but the pediatrician and orthopedic doctors have pointed out the child has spasticity. So I just wanted to clarify it before I start, because based on the case presentation given to us, I had prepared for hypotonia. So the child has spasticity, right?
Ma'am?
Yes.
I'm a pediatrician.
Yes,
the
yes.
child has presented in February. So I have
Yes.
recited all the points which I noticed on that clinical finding, and then we have started evaluation.
Okay.
This
So
is the current status. Yes.
So currently the
low-
child
is overall tone of the child is hypotonia.
Okay, fine.
Okay.
Thank you.
Yes. Yeah.
So based on the
Sorry, Trupti ma'am, Prajakta here.
yes.
So I guess currently the patient is having hypotonia in trunk and limbs.
Okay, fine.
Yes, ma'am.
No problem. No, just a query because two speakers have spoken about
Yes, ma'am.
spasticity.
Yes,
and-
ma'am. I
yeah.
think they wanted to present a prior picture
No problem. No
when she
issues.
had
Okay.
come earlier.
Thanks.
Yes,
Thank you
ma'am.
so much. Yeah.
Thank
So
you.
based on what the history and all has been given, as an occupational therapist, I will be assessing on the following areas. So first will be on neuromuscular status, where I will be looking for a postural control and muscle tone. As it has been said, she has hypotonia, and then we'll be looking out for postural muscles, whether she has co-activation in that muscles, whether there is any selective isolated control in the muscles. Then muscular skeletal status, since there are contractures and tightness is present, I will be looking for her joint stability and joint integrity and active range of motion. Also, since she has hypotonia, and hypotonia leads to poor mobility, and therefore the exploration of her environment is limited. This further limits the sensory experiences of the child. So this child will tend to have some sensory issues. So I will be looking into sensory processing issues, and I will evaluate her sensory modulation, discrimination, and integration skills. Further, in ADL, since she is dependent on ADL, I will see how she uses her body to do her daily activities. How is there are any compensatory movements which are there, which she's adapting during her ADLs. Then if any adaptive equipments are used, how effectively the adaptive equipments can be used, are being used by her. Later, occupation, for her, the occupation will be play or going to school. So I will be evaluating how she interacts with the toys around and the environment around. And if she's going to school, she's not going to school right now. But then if she has to go to school, how can she be made independently, be in the school? Then look at her psychosocial and emotional factors, like how can she participate, look at the physical layout of the environment, her accessibility and adaptations which can support her mobility and participation. Also in contextual factors, I will look for her family understanding, her support and ability to implement her therapy recommendations. Also look at the family dynamics and her emotional responses. Next slide. Next slide, please. Okay. Since she is at GMFCS 4 or 5, whatever, the focus of my treatment will be mainly on prevention of secondary impairments and using of adaptive equipments and technology for her mobility and participation. So first to intervene, I will first say that since there is a neuroscientist who has said it takes 500 neurons to learn a new thing, but it almost takes 5,000 neurons to unlearn any learned thing. So better be delayed, but I will see that whatever is been taught to her is always in a right alignment. So, it becomes a good thing, and the secondary impairments are prevented. So as it has been pointed out that a child is already doing some activities, functional activities. So she's definitely using some compensatory patterns. So first, while looking for postural control, I will see her alignment. So for her, I can use some SPOs. It's a stabilizing pressure input orthosis, which is simple lycra garments, which can be used as a compression, and it's like a second hand on the therapist, a child, so that a therapist or a mother is not throughout the day. So that time that SPOs are on and the child can be stable in an upright posture and can use her hands or body for functional activities. And also if she can't sustain her neck, we can give a simple roll at the neck, so that helps to maintain her balance. So with the SPO and neck rolls, she can have an upright posture, which is very stable, and she can use her hands and body for functional activities. Later with NDT principles, I will be working on facilitation of her motor milestones and also inhibiting any abnormal patterns she has, and will be working for her transitions, which she is lacking. Further, as we said, she might be having any sensory issues. So my treatment plan will be continuing more with dynamic surfaces and with lots of suspended equipments, which will with a lot of proprioceptive inputs in it, so that it will help her to develop her body and space awareness, and also with environmental modifications. Basically, we have to modify an environment so that she gets some positivity. So we can modify her sitting arrangements, like giving her a good chair, and with all these adapted equipments, which will enhance her participation in at home as well as in school. Play, which is also an integral part of her occupation. We can suggest her, as the child therapist also said, that she likes to be in a group. So we can modify her environment, like make her sit in a very good supported chair, and make her play with all the supported equipments, which will help her to be little independent, and get her confidence that she can be engaged properly, and it will enhance her engagement in play. Also, the toys which are used can be modified, like you can be modifying it with size and colors, which will be very really interesting for her, and the grasp will be better. In her ADL, we can use adaptations for her utensils which she is using, like just giving her some broad handle spoons and all, which can help her to grasp it properly. And with a proper sitting, she can use her utensils properly. At family education, like parents really play an integral role in a therapy, as they are the ones who are spending longer time with the child. So educating them to how to support her at home, and providing them with strategies which can be helpful in their daily care and activities will be important. We can help them in guiding them in positioning the child or handling her, and a safe mobility within and out of the house, and that will really be helpful for her. Also, we can encourage the parents to engage her in age-appropriate activities outside and within the house, which will boost her confidence. We can she can be put to school, and in school, presently, since she's 5 years old, she can go to a play school, and there we can give her a good chair where she can be upright and sitting for some time with good support. And there at least she will be getting along with children there, so there'll be a good peer interaction for her, and that will really give her some motive, like she is there and learning something, and it will help her in her overall development and well-being. Also, I think I'm covered everything.
Yes.
Yes.
Thank you.
Yeah, thank you.
Thank you, Dr. Trupti. I think we'll go without further ado to Dr. Priya Shah. Yes,
Thank
the
you.
speech pathologist.
Yes.
You have 7 minutes. Yes. Thank you.
Good morning, everyone. I'm Dr. Priya Shah, a speech pathologist, and I'm a private practitioner. I'd like to start by saying, as an ex-assistant professor from Nair Hospital, it always feels good to be back on any Nair-related platform. Moving on to the case at discussion, from a speech point of view, in terms of intervention, we would start off with a whole panel of assessments, then working out a good management technique, followed up by heavy family counseling to get the support of the family. When it comes to the assessment, case history, which has pretty much been covered, but getting an overall family history, birth history, milestones, but more from a speech point of view, we would work on observing the family dynamics, observing interaction between the child and the parents, seeing how is a form of communication right now. Starting on the communication assessment part, we'd work out on an extensive cognitive prerequisite for language assessment where the child's eye contact, attention, memory, imitation skills, basic skills which are required to acquire the communication naturally and learn the teaching approach of the child would be very essential. Once we have an idea of what is the cognitive prerequisite of the child, further detailed language evaluation would be possible. There are a lot of formal testings which are available for that age group. Understanding though the child is 5, and earlier testing like 3D LAT or 3D three-dimensional language acquisition test or assessment of language development. These are the formal testings that could be done. Overall, checking the child's vocabulary in terms of what the child understands versus how much the child uses. It has been said that the child just uses 2 words, give and mom, but understands different emotions, understands kinship terms, and what are the overall vocabulary of the child. Expression also, what is the mode of communication? Maybe there are 2 words, but does the child point? Is it non-verbal? Is there pulling or nudging? What is the language usage of the child? That will give us an idea of the language evaluation and language age in terms of the receptive language age, what the child understands, and the expressive language age, what the child uses. Moving on to the oromotor evaluation, it is very important to understand what is the oral structure, how is it at movement and at rest, what are the vegetative functions of feeding in terms of sucking, sipping, blowing, how is the child chewing. It was mentioned that the child does eat finger foods, but yes, there is chewing issues. What is the consistency of the meals that the child is having? What is the intelligibility in terms of the few sounds and words the child uses? Is there any babbling, and what is the intelligibility of that? Knowing the fact that this is an arthrogryposis case, with the low set ears, it's always good to have an evaluation of hearing also because they are known to have some middle ear issues. So what is the hearing assessment along with its impact on speech is important. Over and above that, next would be the social pragmatic skills. What are the pragmatic skills? It was mentioned that the child is likes to interact with peers, likes to share things. But overall, what are the social pragmatic skills in terms of turn taking, turn waiting? The higher pragmatic skills like topic maintenance, conversational repairs are not applicable because the child is nonverbal. But are there any behavioral concerns? Are there any temper tantrums which are there? How is the communication hampered because of the temper tantrum? The child gets what they want, what she wants because of just a temper tantrum, and hence the communication itself is restricted. What are the family and peer interactions? This gives a whole idea on the whole assessment aspect of the child. Moving on to the management, again, working purely first on the cognitive prerequisites of the child because we do not prefer in sitting and teaching speech. Speech and communication should come in very naturally. It should come in spontaneously by what they hear around them in the environment and what they are exposed or stimulated to. So working specifically on the attention, on memory, on the child's imitation skills to help improve the cognitive skills of the child to pick up language. Working on need-based vocabulary, specifically what the child wants, specifically considering the environment of the child, working on a lot of language skills and concepts. Now, given the paucity of her communication skills and the age of the child, where she's over 5, but her language age does not seem to be close to more than 1-year-old, in order to prevent a further delay in the communication skills, the child should be exposed to AAC or augmentative and alternative communication. This helps the child to communicate other than speaking so that she can express her needs, her thoughts, her feelings. You could have anything from a low-tech AAC mode, which could be gestures or Macaton, but that also depends on how much physical dexterity she has. Something as simple as picture exchange or pointing, or depending on the financial capability of the family, high-tech devices like apps or tablets or eye gaze devices which need to be there. Working on the oromotor concerns of the child, Once vegetative functions of chewing and any other oromotor issues are taken into play, that itself provides a big backup on expressive vocabulary building up with the oromotor concerns. Then are the social pragmatic skills, which will help involve and include her in general conversations. Lastly would be on the family management. Could I have the next slide, please? Tracking overall day when working with the family, meals, sleep behaviors, activities, ALD, explaining the results and correlating with the other professionals. It's always best to create a conducive environment for language stimulation and expression, given what restrictions the child has. In any form of therapy, it's always good to have the parents present in the session to observe and perform. Have a uniformity with all family members. It's not only the responsibility of the mother to take care of the communication. There should be equal communication with everyone. Follow up with a home program and videos is what helps in overall development of the child. And lastly, could I have the last slide? Family involvement is critical. Working with the team is what is important. Reassessment every 6 months helps in order to understand what the child's level is and work out a plan for the child further ahead. That's my time.
Thank you. Thank you, Dr. Priya. I will go on to Dr. Priyanka. You can self-introduce and
Good
start.
morning, everyone. Yeah, thank you, ma'am. I hope I'm audible.
Yes, you are.
Good morning to everyone. I am Dr. Priyanka Jagtab, currently working as psychologist at KEM Hospital, Mumbai. I'm also a member of Psychologists Collective. So my focus will be to pointing out assessment and interventions from a psychological point of view. Of course, we start with the case history because case history is very crucial for understanding the intellectual functioning as well as the adaptive behavior, especially to note that the onset has been during the developmental period. It will also emphasize on understanding the etiological factors as well as the other comorbidities. As we understand in this case, there are neurological, psychiatric, as well as behavioral comorbidities. Behavioral observation assessment is very important to corroborate the clinical history with that of intellectual functioning and behavioral repertoire. Of course, behavioral observation in terms of mental status examination can be done, as well as there are various formal behavioral checklists. We have Connors rating scale, we have child behavior checklist, which can help understand and identify a number of behavioral concerns that are associated with the condition in terms of stubbornness or inattention, defined behavior, hyperactivity, difficulty sustaining attention, and so on. Next, we can move on to developmental scales for identifying the DQ. No, please stay on the slide. Thank you. The developmental scales or identifying the DQ, we can use developmental screening test or the Jessel's developmental schedule, depending upon the age of the child. Of course, there will be a lot of other developmental scales that are available. Developmental scale is basically useful to identify the degree to which the child has progressed through the typical developmental milestones. As we understand here that the child is a case of GDD. Along with developmental scales, we can use scales for adaptive behavior functioning. The one most predominantly used one is the Venlance Social Maturity Scale, VSMS, which involves a comprehensive evaluation of the life skills as well as the social skills depending upon the different age groups. Along with that, we can also use the DSM-5 list for specifiers, especially when we are trying to look at the intellectual point of view. So after developmental scales, adaptive scales, we move on to the intelligence assessment. In intelligence assessment at this point in time, I think VSMS will be a better option because the child has grossly delayed development in terms of motor functioning as well as speech functioning. When the motor functioning develops because of the physiotherapy and the occupational therapy, sanguine form board test is another test that can be considered. And of course, as the speech improves, there will be a number of other tests that will be available, like the Kamath-Binet test, Wechsler's intelligence for children, as well as MISIC, Mellon's intelligence scale for Indian children. And finally, we come to the disability assessment. Disability assessment is important from the point of view of certification for ID, intellectual disability. According to DSM-5, there are 4 levels of severity, which is a mild, moderate, severe, profound, that is based on the intelligence score, the IQ obtained from the intelligence test. So certification of ID can be done based upon the severity level. Focusing on the interventions, next slide. Yeah, thank you. So focusing on the interventions, first and foremost, it is very important to formulate a proper treatment plan, which will be based on the severity level of the intellectual functioning, the medical condition, the comorbidities that we have, any psychiatric problems, behavioral issues that the child is experiencing, focusing on the psychosocial factors or the psychosocial adversities that the family as a whole is going through, and considering the global functioning of the child. Providing them with the appropriate measures, medical as well as psychosocial interventions is very important, as we have all discussed the importance of early intervention. Most important thing over here is psychoeducation for the family members, especially the parental counseling, because creating awareness is very important for providing information regarding the nature, the needs, and the management of intellectual disabilities, as well as the impact of the different comorbidities that the child is having. As we have discussed already, genetic counseling again is very important, because majority of the cases, almost 2/3 cases of ID will have a genetic etiology. So genetic counseling is mandatory. The risk of reoccurrence, the possibility of prenatal diagnosis, the prognosis of the disorder, all of these are important. So it is very important to develop an individualized treatment plan, as well as it is important for timely evaluation of the effectiveness of the different interventions that we are utilizing. So based on the assessments, we will have the interventions like behavior modification. Behavior modification have got different steps involved. First and foremost is the identification of the problem areas. What are the problem areas or the target behaviors that need to be selected? Second thing is having a proper functional analysis in order to understand the antecedents of a particular target behavior, as well as the maintaining factors that have to be dealt with. Then we have different behavior modification techniques that include positive and negative reinforcements. It includes token systems, timeout, stimulus control, or simply restructuring of the environment. So depending upon the needs of the child, the current level of the functioning, and the target behaviors, we can identify different techniques, and that can be utilized according to the needs of the child. And of course, once the behavior has been learned, we need to maintain the newly learned behavior. So that's important from the behavior modification point of view. As we are talking about the adaptive skills and the social skills training, adaptive skills basically are skills related to the personal care and hygiene, problem solving, expressing needs, as we know that the child has minimal speech, but expressing it or pointing out through behavior. So what kind of adaptive functioning the child is having, and plus improving the adaptive functioning. The social skills will include teaching assertiveness, communicating emotions, sharing, bonding, then the kind of social interactions that the child is having, and of course, relationships. So depending upon the current level of the functioning, we can always build upon step by step in terms of adaptive functioning as well as social functioning. Now, when we talk about adaptive and social functionings, we are looking at it from a functional point of view and a lifespan point of view. Functional approach will focus on the current level of functioning so as to enable the individual to function better on everyday tasks. Whereas when we are talking about the lifespan approach, it will focus upon the different developmental needs at different stages of life and how to adapt to the environment at different point in time. Looking at the education point of view, I'm not really very sure whether the child is going to attending school, but looking at the case profile, the GDD with intellectual disability, special schools, enrolling the child to a special school is very important to cater to specific educational requirements, keeping in mind the disabilities of the child, along with a combination of integrated learning or integrated education, which emphasizes on helping the child to make connections between the concepts that they have already learned through the different experiences and then applying that learning to different novel situations or complex tasks. So that is the whole purpose of providing education, special schools along with integrated education. And of course, finally, we talk about family-centered interventions, which is the most important thing. Creating awareness is one thing, but at the same time, helping the parents, helping the family make meaning of the condition and develop a sense of control is very, very important, because as we understand that intellectual disability is a condition, so it's not reversible. And the intelligence is something that they will have to understand what will be the consequences of having a particular severity level of intellectual disability. So individual counseling is very, very important for the parents and the family members. Parent training programs at different stages are very crucial. Group counseling for them to understand the issues, understand and discuss what are the different problems experienced by similar children in different parents. Of course, self-help groups are very, very important. And along with that, the caregiver should be regularly screened for any stress-related disorders, because many a times the parents themselves might be going through adjustment disorders or anxiety issues, or maybe experiencing depressive tendencies. And of course, we have to focus on the management of such stress-related disorders.
Thank you.
Another important thing is providing information about the right resources for healthcare, different kinds of therapies, education, vocational and occupational needs, and also all the policies and the provisions which are available for children with intellectual disability, with the focus of creating supportive environment which is conducive to child's emotional as well as overall well-being. Thank you so much.
Thank you, Dr. Priyanka. That the last bit was extremely helpful also. I think we as psychiatrists also need to look into it. Ms. Swati, you are the last speaker. Please keep to the time. I think we have almost overshot our time by about 5 minutes.
Yes, ma'am. Yes,
Swati, please continue.
I'm Swati Kerekar. I'm a special educator. Next slide, please. 5 years old child with a developmental delay. ऑटिज्म मुझे इसीलिए लगा था क्योंकि सेंसरी इशू एंड अटेंशन का था, लेकिन जैसे डॉक्टर कोमल ने कहा कि सोशली इंटरेक्शन जोहाना का बहुत अच्छा है और तो माइट भी नहीं होगा. असेसमेंट, एजुकेशनल असेसमेंट ऑफ चिल्ड्रन विद ऑटिज्म टीका कर सकते. फ्लोर टाइम एंड जैस्पर इसलिए कि 0 to 6 ईयर जो एज है ये अर्ली इंटरवेंशन का बहुत क्रूशल एज है, जहाँ पे जॉइंट अटेंशन, सिंबॉलिक प्ले, एंगेजमेंट, रेगुलेशन का ये कर सकते हैं. नेक्स्ट स्लाइड प्लीज. हाँ, IFSP जैसे कि इंडिविजुअल फैमिली सर्विस प्लान 0 to 6 में बहुत इम्पोर्टेंट है, क्योंकि फर्स्ट की अटेंशन, इमिटेशन, ये सारे स्किल डेवलप हो. मोटर स्किल, लैंग्वेज एंड कम्युनिकेशन, कॉग्निटिव, प्ले स्किल, सेल्फ हेल्प स्किल पे ये प्री रिक्विजिट और इम्पोर्टेंट स्किल है, जो कि उस पर वर्क करना और फैमिली को भी उसमें इन्वॉल्व करके सब मल्टीपल डिसिप्लिनरी टीम का भी रोल उसमें इम्पोर्टेंट है. नेक्स्ट स्लाइड. टीचिंग स्ट्रेटेजी में अलग अलग स्ट्रेटेजीज हम यूज कर सकते हैं. VAKT मेथड, सेंसरी अप्रोच, जो है ना अर्ली इंटरवेंशन स्मॉल चाइल्ड है तो इसलिए फ्लोर टाइम, जैस्पर, टास्क एनालिसिस, क्योंकि डेवलपमेंटल डिले है तो ब्रेक करके एक्टिविटी हमें लेनी होगी. डेमोन्स्ट्रेशन, रिपीटेशन, वही एक्टिविटी का रिपीटेशन करके. पॉजिटिव रिइंफोर्समेंट बहुत इम्पोर्टेंट है, क्योंकि जो एज है इसमें मोटिवेशन देना, पॉजिटिव रिइंफोर्समेंट देना बहुत इम्पोर्टेंट है. नेक्स्ट स्लाइड. जैसे कि पेरेंट्स एंगेजमेंट प्रोग्राम है, पेरेंट्स को ट्रेन करना, उनको सिखाना कि किस तरह से एक्टिविटी घर पे आप ले सकते हैं, क्योंकि हम IFSP जब प्लान करते हैं तो फैमिली का रोल भी उसमें बहुत इम्पोर्टेंट हो जाता है. पेरेंटिंग काउंसलिंग एंड गाइडेंस भी बहुत इम्पोर्टेंट है, क्योंकि चाइल्ड को एक्सेप्ट करना, उसके साथ अभी जो है ना कि लोअर लिम्ब अफेक्टेड है, और तो सोशलाइजेशन के लिए लेके जाना, सोशल एटमॉस्फेयर क्रिएट करना, ये सारी चीज़ें भी पेरेंट्स को काउंसलिंग करना और उनको बताना ज़रूरी है। नेक्स्ट स्लाइड प्लीज। जैसे कि मेडिकल कंडीशन है, तो मेडिकल चेकअप का फॉलोअप लेना, थेरेपिस्ट, ऑक्यूपेशनल थेरेपी, फिजियोथेरेपी एंड स्पेशल थेरेपी, स्पेशल स्पीच थेरेपी ये देना, एजुकेशन सपोर्ट भी बहुत इम्पोर्टेंट है, एडेप्टिव इक्विपमेंट जैसे कि क्लासरूम में चेयर्स हो, वो सारी चीज़ें, और घर पे भी एडेप्टिव इक्विपमेंट का यूज़ होना बहुत ज़रूरी है। उस तरह से पेरेंट्स को भी गाइड करना ज़रूरी है। नेक्स्ट। थैंक यू मैम।
Thank you, Swati. I think you managed to finish way before time, so it gives us about a few minutes for discussion. Any points? I think on the chat, barring my own request to psychiatrists to post areas, I think the psychologist has anyway, conveyed the areas as far as mental health professionals coming in with regards to family intervention. And I think particularly, I think it is important to again reiterate, it is not only the mother's responsibility to come for therapy, take care of the child. And Swati, it is very nice that you put that point of adaptive equipment even at home, which can actually be very, very useful and always required, especially when you have a multiply, disabled child who is growing up. I think that is an extremely important point. Thank you all panelists for sharing your views and keeping to what the mandate was in terms of interventions. Queries, I think I can see just a comment by Dr. Sophia Azad along with GMFCS, MACS, DDAX, and CACS should be evaluated. Dr. Sophia, if you're still there, would you want to elaborate on what you mean by an overall comprehensive evaluation?
Can I take that question?
Yeah.
Yeah, it's that's just the classification system, as GMFC is there for gross motor, MAC is for the classification of hand use, and CFCS is for the speech level, at what level the communication issues are, and EDAC is eating and drinking, so the ability of the child to eat and drink. So that is the classification system. So I think ma'am wants to say that if you have done all that, you get a comprehensive picture of what level the child is.
Yes, thank you. Thank you, Dr. Trupti. Yeah. Any psychiatrists have any comment? I know psychiatrists have not been in this panel, but anyone wants to talk? I would like to start with saying that we have had children who have been similarly, having multiple disabilities, and a couple of them are wheelchair bound. And what in one case, as it was seen, the mother was the primary caregiver, but the husband and the father was very supportive. Unfortunately, after the child's death very early, the marriage broke down. So that was something that happened. I think they just were very fatigued by the end of, the duration of having taken care and being very supportive to each other and to the child. Somehow there was very little left when they had to reconnect, though it was advised when the parents were counseled about it after the death of the child. So this is another thing that can come up, where probably masked grief and masked depression can lead to relationships breaking down. In another case, the child still comes to me. Of course, there are behavioral issues which need to be managed medically. I think that has been, sort of addressed by the various therapists here. Anyone else? Anyone else wants to add to these comments?
May I say one thing?
Yeah.
Yes. So a lot of time we've seen that working on the child is not enough. A lot of times the issues with the parents, like you just mentioned, this was post the child's demise. But even while they are working with the child, unless the family dynamics is worked upon, the amount of success that we'd expect on the child is limited or is reduced. And at the same time, a lot of times during our counseling, we do suggest that the parents need to go for counseling between the husband and wife, or just the mother probably would need counseling. But in our experience, their priority is so much on the child that something for themselves is very low. But we do stress importance on the same, because it will go a long way in improving the child's overall success in therapy.
And Dr.
Can I say
Jaya
something?
Jacob, yeah, Dr.
Can I
Jaya
say
Jacob
something?
has just commented also about the financial burden on the family for a child with multiple disabilities. Yes. Yeah. Someone else was commenting.
Yes,
Yeah.
Sukhada here. Actually,
Yeah.
a very well-raised point that it becomes very important to therefore engage in constant parent coaching and counseling and relationship management. A lot of times, internal referrals and getting them into support groups works wonders. When that is something that is addressed at a global level, then we also start seeing a lot of change in the child's presented behavior, or even if it's an adult client, the entire decorum of the case changes. Yeah, parent contribution could mean a lot of it. A lot of times they could also be conducted into support groups in which they're interacting with other parents in terms of hobbies, developmental goals, because that can really take care of a lot of burnout that can be seen often in parents.
Yeah. Thank you, Dr. Shukla.
I
Yeah.
would just, hi, yeah, my name is
Yeah.
Eman. I would just like to add to everything that has been said. Thank you for the lovely webinar, first of all. I have an MSc in clinical psychology and I'm practicing as a counselor. And I have often seen children with neurodivergence or autism, and I've worked very closely with them. And while I think that parent support is important, I feel like as psychologists, we tend to individualize the issue and ignore the social support aspect of it. Like, I feel like we should center disability justice and mental justice. I feel like we should center the person who is experiencing the problem and ask them. Like you mentioned, consent is important, right? Consent in terms of who wants to have a conversation, for example. I feel like we should also center more neurodivergent people. Like, we should include them. We should have active conversations with neurodivergent mental health practitioners. I feel like that will immensely improve our quality of, health practicing that we do. And that's incredibly important given the society that we live in, since we're still fighting a lot of stigma, we're still fighting a lot of battles when it comes to just gaining basic access to mental health resources, right? So I feel like centering that and centering disability justice and centering mental justice and being cognizant of social locations, why certain sets of people, why certain groups of people tend to fall ill or tend to experience mental health illnesses. I feel like that is extremely important. Thank you so much. That's all I wanted to add.
Thank you. Thank you, Eman. Yeah. Sriharsh, you wanted to speak? Yeah.
For this platform. And I think before educating the community, it's extremely important. I think this platform is the best one to understand the role and the professional boundaries of each professional. Also, I've seen like people I mean sharing their viewpoints from their specialty point of view. Knowing what the role, especially, I mean, when I talk about occupational therapy, the role is so less known, maybe because we are less in number. But however, whenever there is whenever there is an occupational injustice or deprivation, I think an occupational therapist would be a great help to complete the entire rehabilitation process. I would want to reverberate to all the medical practitioners to actually be cognizant about the field of occupational therapy and physiotherapy and their distinct roles in any rehabilitation processes.
Yeah, thank you. Yes, definitely. I think there's a comment which Dr. Ravikant has said, that there's a lot of information overload, and providing handouts would be beneficial for discussing the high level of challenges. Yes, actually, when we started out with actually providing an overview of all the disciplines that are involved, providing some area where we could connect. And because there are lots of people who have logged in from places where all these very specialized therapies are not available. And I think it is also from a psychiatrist point of view, for example, young students not even being aware that these are the interventions that are possible and feasible. If a a therapeutic a therapist is available. So this was actually an introductory sort of seminar series that was going to address that. Definitely the request for, providing some sort of handouts is there. All these webinars are they are videotaped, and with regards to that, like you can go on the IPS West Zone branch YouTube channel, and you can always go back and see what has been discussed here. Barring that, thank you, Ravikant, for for that suggestion. Next time we'll keep it in mind. We will be, of course, meeting at the last Sunday of August, that is 25th of August. Are there any more queries or questions or comments? Please fill the feedback form. I think I keep posting again and again. It's very important for us to plan the next session. If you all have interesting cases, and this is not only for the panelists, but anyone who's watching has interesting cases, please put that case. You can always write into us, and we will see how that can be taken up in terms of for discussion. If there is a good case, we would definitely welcome such a discussion. We could add you on the panel also. It's an open panel system from different disciplines. Yeah, Prajakta, I think, has again added the feedback form. So if there are no queries, I think it's been wonderful. Thank you all the panelists for sharing your views. And though, of course, we did run a little over time, but we are getting better. We are about 6 minutes over time. That is still all right. And I think we are managing to do time management along with providing inputs. And it has been an excellent learning for all of us. Dr. Alka, should we wind up? Would you want to say anything?
No, I think that's very good. Even the second panel, we can close for this.
So we can close for today. Thank you all panelists. Thank you all the, all the different association members who have joined in today on a Sunday morning. It's been a good 2 hours of discussion. Please fill the feedback form. I, of course, thank the IPS West Zone branch, the net support that we get